Bismillahirrahmanirrahim. Now we are going to continue our discussion on nevi, and we are going to study the cancerous component, which is the melanoma. So it's basically a UV light induced DNA damage, and that leads to a stepwise acquisition of multiple driver mutations. The risk factors is that if you're living in a sun exposed area, or if you are a fair skinned individual, or if you have a family history of melanoma, or there has been an early exposure to strong rays of sunlight in early life. And then next they said that a lot of people who have familial melanoma, they have a driver mutation. They have a mutation in the CDKN2A, which is basically at the chromosome 9, ठीक है, लॉन्ग आर्म 21.21. सो उसमें बेसिकली होता है कि दिस म्यूटेशन, अगर ये वाला जो कॉम्पोनेंट है, दैट इज़ बेसिकली रिस्पॉन्सिबल फॉर producing two tumor suppressors P16 and P14. P16 is basically responsible for regulating the G1 to S transition, whereas P14 positively regulates the P53 tumor suppressor. So when you'll have this P16 म्यूटेशन या P16 सही तरीके से रेगुलेट नहीं हो पाएगा, या P16 सही काम नहीं करेगा, तो अनकंट्रोल्ड ट्रांजिशन होगी फ्रॉम द G1 टू द S फेज, विच इज़ बेसिकली द माइटोटिक स्टेज, इसमें DNA डिवाइड हो रहा होता है. सो इसमें बेसिकली अगर हम इसकी मॉर्फोलॉजी की बात करें, तो या इसकी ग्रोथ की बात करें, सो देयर इज़ अ रेडियल ग्रोथ एंड हॉरिजॉन्टल ग्रोथ, एंड विल स्टडी दैट. सो बेसिकली होता क्या है कि लेंटिजिनस हाइपोप्लेजिया, द वे वी डिस्कस्ड इट इन डिस्प्लास्टिक नीवस सिंड्रोम, दैट देर आर सेल्स इन द डर्मो एपिडर्मल जंक्शन, ठीक है. और ये मतलब जो एक बिनाइन लीजन होती है वो कैसे बनती है, दैट इज़ बाय द BRAF एंड द RAS म्यूटेशन दैट वी ऑलरेडी डिस्कस्ड इन द लास्ट वीडियो. फिर उसमें उन्होंने कहा कि जब हमारे पास ये BRAF और RAS म्यूटेशन थी, एक लेंटिजिनस हाइपोप्लेजिया हो गया, एक डिस्प्लास्टिक नीवस बन गया, या एक मेलानोसाइटिक नीवस बन गया, इट इज़ ऑलवेज फॉलोड बाय सेनेसेंस, विच इज़ बेसिकली प्रोलिफरेशन स्टॉप्स, ठीक है. बट यहाँ पे क्या होता है कि देर इज़ अ टीलोमेरेज म्यूटेशन, जिसमें क्या होता है कि there is no breaks in the senescence, and that leads to a melanoma in situ, and that leads to radial growth which is within that epidermis, ठीक है. और फिर उसमें क्या हो जाता है, लॉस ऑफ P16, which is basically because of the mutation in CDKN2A, which leads to the vertical growth, and इसमें क्या होता है कि the tumor starts growing into the deeper dermal layers, ठीक है. सो इसमें क्या हो गया कि देयर इज़ अ लोकल इन्वेजन एट दिस स्टेज, ठीक है. अभी तक अगर जो वो पर्सन है, ठीक है, वो आएगा, उसकी लोकल इन्वेजन है, ठीक है, तो हम सर्जिकली उसको एक्साइज कर सकते हैं, ठीक है. बट उसके बाद क्या होता है कि P53, विच इज़ बेसिकली P14 जिसको रेगुलेट करा था, P53 वॉज रेगुलेटेड बाय P14, अगर उसके अंदर म्यूटेशन आ जाए या फिर P10 के अंदर म्यूटेशन आ जाए, तो दैट विल लीड टू metastasize, the tumor will start metastasizing, and इसमें क्या होगा कि it will spread vertiginously to the other parts of the body, like the liver, the lungs, your brain, as well as virtually any other site that can be seeded hematogenously, ठीक है. एंड फिर उसमें एक चीज़ जो होती है that is helpful and that gives us some hope of cure, that is immune evasion. So your immune system starts attacking, and at this point हम लोग immune checkpoint inhibitors देते हैं या BRAF inhibitors देते हैं, जो basically क्या करते हैं, abrogate करते हैं the response, the immune response, so that we can better fight with the tumor, ठीक हो गया. So immune evasion is very important. One thing that I just want to mention, that melanoma is not necessarily supposed to be on the skin. It can be at any other mucosal site, and in that case then it's called a cutaneous melanoma. So it can arise in the oral and in the anogenital mucosal surfaces. It can arise in the esophagus, in meninges, as well as the eye, but they have different molecular pathways. They're different from this molecular pathway that we just discussed, ठीक है. सो हाउ कैन वी डिसाइड what is the status of the tumor, how malignant is it, and how much how much hope of cure is there. So that is basically based on the sentinel lymph node biopsy, that we obtain a sentinel lymph node biopsy, and we check that what is the Breslow thickness, what is the thickness that basically correlates with, if there's an increased thickness, then that reflects a worse biological behavior, ठीक हो गया. And if we just look at the diagram that is given in Robbins and Cotran, ठीक है, that how a melanoma basically looks like. So they're basically having large cells, they're having large nuclei, and they have a cherry red nucleoli. The immunohistochemical stains can be helpful in telling us about the metastatic deposits. And the nucleus is basically having very irregular contours. Why is it having irregular contours, or why is it having a very irregular color? That is because the chromatin is just characteristically clumped at the periphery of the nuclear membrane. ठीक हो गया? So when you present to a doctor with a mole, and that which basically, let me show you a picture. Yeah, so the doctor will use this dermatoscope, and he'll basically see the lesion under the microscope, and we'll match the ABCDE, which is basically that how much asymmetrical is it, what is its borders, how are its borders, are they symmetrical, is it changing color, what is its diameter. If the diameter is more than 6 millimeters, then it's scary, and if it's evolving, which means that it was initially small in size, and now it's growing. The patient will mostly present with pruritus or maybe pain, and that's again a warning sign. And the patient may complain that there is an irregularity of the borders, or maybe there is a change in the color, or maybe the person may mention that I just saw it today and it wasn't before, and it's rapidly enlarging. Then that's basically danger signs. Yeah, and just if we look at the picture to have a detailed description about the morphology. So the lesions, they tend to be larger than nevi, and they have irregular contours, and they have a variable pigmentation. Macular areas indicate superficial, macular areas, they basically indicate superficial radical growth. So there's a radical growth. Take it with elevated areas indicate dermal invasion, that's basically the vertical growth, and the radical growth phase with the spread of the nested and single melanoma cells within the epidermis, and the vertical growth phase, which is having nodular aggregates of infiltrating tumor cells within the dermis. They're having nodular aggregates of infiltrating tumor cells within the dermis. And the D diagram basically shows that melanoma cells, they have hyperchromatic, irregular nuclei of variable sizes. They have prominent nuclei, and there's an atypical mitotic figure that is present in the center of the field. And the inset shows a sentinel lymph node containing a tiny cluster of metastatic melanoma, and that's detected for staining for the melanocytic marker HMB45. So let's just precise what we have read. So most melanocytic nevi have activating mutations in the BRAF, or less commonly RAS, but the vast majority never undergoes any malignant transformation, and it stays as lentiginous hypoplasia maybe. So most sporadic dysplastic nevi are best regarded as markers of melanocytic risk rather than pre-malignant lesions. They're characterized by architectural disorder and cytological atypia. Now, melanoma is highly aggressive malignancy, and tumors only few millimeters in thick can give rise to deadly metastasis. In most cases, melanoma progresses from an intraepithelial, that is in situ, to an invasive dermal form, and characteristics of the dermal tumor, such as the depth of invasion and mitotic activity, they correlate with survival. I hope you've understood what I've explained. So thanks for watching the video.